Hello, everyone. I am going to start this webinar. I apologize for the puppy barking. He just picked the right time to bark. Hopefully he will stop. Nothing that I tell him will make him stop, so maybe he will. Okay, let me start sharing my screen. And that way also we'll get some time for people to actually slideshow. Here we are from the beginning. All right. Are you guys, do you have the full screen now? Yes. Okay. All right. All right. Awesome. Well, let's start. I mean, this is probably one of my favorite webinars just because it's so common and it's not talked enough about. I would say, and I'm gonna start with like some statistics, but I would say that at least at the program at CRS, which is where we work, 80 to 90% of our clients have some sort of issue with substance use. I wouldn't say not necessarily a diagnosis, but it's part of their presentation. So it's always good to pay attention to substances and the role they play in the presentation of all our clients, even if we are running a primary mental health program. So let's start with addiction. And again, I wouldn't say that all our clients or many of your family members maybe meet the criteria for addiction, but this will help us sort of center us and recognize what is an addiction and also what are symptoms that are associated with substance use, which is a lot more common with clients with a primary diagnosis of mental health. So addiction is a chronic disease. That's the first thing that we need to know. And like a chronic disease, we will look at it mostly like we look at diabetes, like that we look at heart disease, like we look at high blood pressure. It's something that has to be treated always. It affects the centers of reward and motivation and memory in the brain. And that's why it's very hard for anyone that has a problem with substance use to stop, because it goes beyond motivation or beyond willpower. You know, the centers of, again, reward and memory and motivation have been affected by the chronic exposure to substances. It is obviously a biologically based disease that has psychological symptoms and social consequences, and spiritual consequences for the people that are suffering from addiction. And the main behavior, the first thing that you're going to observe is that people with addiction will do anything they can to obtain the drug that provides this like reward at the brain level, in spite of all the consequences, even if they're like severe and, you know, catastrophic sometimes. So this results in the inability of any person with addiction to abstain, and the inability to control any kind of behaviors that will take them away from substances. So you see people doing sort of irrational things, or things that you're like, why are you doing this? To obtain the drug, to maintain the behavior, even though from outside, from where we're at, we see that this is not taking them to any good place. You know, and again, without calling it addiction, sometimes this happens a lot with our clients and self-medication, right? Using some substances will be easier and more attractive to them than being compliant with medication, for example, because it affects the reward system and it provides this like immediate gratification that nothing else provides. So again, without calling it addiction necessarily, it uses the same mechanism, and if not addressed as part of treatment, yes, it can become a secondary diagnosis of addiction. Addiction as a chronic disease is characterized by cycles of relapse and remission, meaning relapse, and this is important for some of you that do have someone already diagnosed with an addiction disease, the relapse is part of the illness. Relapse is not necessarily a bad thing in the sense that it doesn't mean the person is doing worse. It just means the person is having symptoms of their illness. And that's important to know, and that's important to understand. A relapse and it's seeking treatment immediately is okay. It's part of the illness. It's no different than looking at someone with diabetes and having an episode of high blood sugar. If it's treated and addressed and the person continues on the medication regime, then it was just that. The issue with relapse is when it's prolonged and exposes them to the consequences that they don't want to have. Deterioration of their mental health condition and all of the psychosocial consequences associated with prolonged use of substances. But again, I think that part of how we can help is changing the mentality that the relapse is, of expecting that there will not be relapse if someone suffers from the disease of addiction. Likely there will be. The question is under what circumstances. If the person is properly linked to supports that they have still a treatment team and social supports that will allow, meetings or other support groups that would allow them to immediately go back on track, then it's just that, it's a symptom. If it becomes prolonged, then we'll have to think a little bit different about that and maybe, think about the interventions for that. But if it's just someone having a symptom of their illness and continuing with treatment, then we're okay. We're still in treatment. Without treatment, the problem with addiction, and it's progressive, and in certain occasions, it will actually deteriorate the brain enough to have severe cognitive consequences. And that's, I think, the major fear, especially for young adults, like most of your family members. You have someone that is, full of life, full of possibilities, and then if chronic use makes them lose cognitive ability, that's, that will be the most serious consequence, the most serious consequence of, aside from that, from addiction. All right, here, a little bit about co-occurring disorders. Again, just so we have an idea that it's very common among people with a primary psych condition. So it's in between 20 and 40% of people with anxiety will be diagnosed with alcohol use disorder. People with depression, similar percentage, 35 to 40%. Bipolar illness, up to 61% of people with bipolar illness will be also diagnosed with alcohol use disorder. And this is just for alcohol. There's similar rates for substance use, or for other substance use, and there's a lot of correlation in between, for example, marijuana use and psychosis, as I think we've spoken about before. So comparing relapse, and this is just to make the case about relapse, right? Less than 60% of people with type 1 diabetes remain fully adherent to medication schedule. So expecting that people with mental illness or expecting that people with an addiction disorder will be 100% adherent to any treatment plan is unrealistic. Like if you think about yourself, are you, let's say you're being treated for high cholesterol or high blood pressure or diabetes or any kind of these illnesses, are you 100% compliant with medication, right? Just a little bit of self-disclosure. I went today to the eye doctor, and she kind of like scolded me a little bit because I was putting some drops in my eyes in the morning, and I guess I'm supposed to put them in at night. But I was like, you want me to be compliant, you're gonna have to let me put them in the morning, because that's when I take my other meds. And at night, I will never take it. I will not do it. So just like, okay, it's better to do it than not to do it. But just think about us and some chronic conditions. We are also not the best at being compliant sometimes. So expecting 100% compliance with our family members' addiction is, maybe an unrealistic expectation. Less than 50% of people with asthma or high blood pressure remain fully adherent to their medication schedule. Again, more evidence that people with chronic illnesses are not very good at being compliant in general. 30 to 50% of patients with that type 1 diabetes and 50 to 70% of patients with high blood pressure or asthma have a recurrence of symptoms that requires medical intervention annually, meaning if you have a chronic illness, you are likely to have a relapse at least once a year. And you're going to need to go to the doctor and adjust your meds or even seek, urgent care or something like that if you have a chronic condition. So the likelihood of that happening with someone with addiction, again, high. Someone with a co-occurring disorder, even higher. Expected, not the best times, but expected. The issue is that there's still a lot of ill-conceived notions about mental illness and addiction, and we tend to still put some sort of moral value to it. So I guess not taking your blood pressure meds is okay or understandable, you forgot, but relapsing on some substance or not taking your psych meds, that becomes somehow morally wrong, and we end up being more concerned about it. Not that we should not be concerned, but again, relapse with immediate supports and with treatment adjacent to that, it's part of the illness. Relapse and nothing happens, that's when we should work. Not relapse itself, it's a symptom. Relapse with lack of services, with lack of support, that's a problem. Best approaches for co-occurring illnesses. Okay, so best approaches is comprehensive treatment or holistic treatment. When someone has more than 2 disorders, an integrated approach is the best. And that means that when the service provider can address all the symptoms at the same time, including medical symptoms associated with the addiction, that's the best kind of treatment when you have integrated care. And there is a lot of movement in outpatient practices, for example, to have outpatient services associated with a medical practice, or outpatient services associated with psychiatry and the availability of groups for substance use. Because if you think about compliance again, it's a lot easier to be compliant with all your services are coming from the same place, right? If you go to your psychiatrist and your psychiatrist says, oh, you forgot to see your doctor, he's next door, go chat with him, you're likely to comply with that, right? If you go to see your medical doctor says, oh, you forgot to go to your group, why don't you check when the next group is? And the next group is next to it. It's a lot easier to do that. People with co-occurring illnesses are more likely to be hospitalized for their mental health or substance use disorder. And that's important also to talk about, because again, addressing everything at the same time will ensure that we avoid that. We avoid accessing higher levels of care if we can provide comprehensive interventions, which will be the goal. If you think about the CRS model, which is again the program that some of your family members are, that's what we try to do. We try to integrate all the services under one roof. So you have the psychiatric services, you have the community integration services, you have the employment services, the psychosocial services, and you have the case managers that make sure that these clients are also compliant with all medical appointments and all the services that they need to have comprehensive care. Because the more that all the things are addressed in one place, the least likely is that this person will have to access higher levels of care. And if they have to access higher levels of care, then it'll be accessed promptly and with a high likelihood that they can resume care with us or at a lower level of care as soon as possible. Okay, integrated treatment leads to better outcomes. It reduces or discontinues the substance use. Again, when you're treating everything at the same time, chances are that either your doctor is going to remind you to take care of your substance use, your psychiatrist is going to remind you to go to the doctor, someone is going to notice that your refills haven't refilled, and somebody is going to notice symptoms early on because there's going to be plenty of eyes on you. There is improvement in psychiatric symptoms and functioning because, again, less relapses or less, the shorter the relapse is, the least negative outcomes in terms of the other illness, right? If someone relapses once and then everything is addressed because they're connected to services, then we just move on. There's no psychiatric decompensation. There's no different no difference in treatment because the relapse was addressed immediately. Increased chance of successful treatment and recovery for both disorders. Same principle. Improved quality of life, decreased hospitalization, reduce medication interactions, increase housing and stability, and fewer arrests. Everything gets better when everything is addressed promptly. No wrong door policy. What is this? In general, the trick or the best approach is that for whatever reason this person comes to treatment, or whatever kind of reason your family member asks for treatment, that's fine. In other words, if someone says, I do have an addiction and I need treatment for that, even though you know that they're also anxious and depressed, does not matter, right? Let's provide the addiction treatment with the integrated services so that they can access everything. If your family member says, I have bipolar illness, but I don't have an addiction, fine, right? Let's treat the bipolar illness. Let's provide the support so that the addiction is arrested the best we can, and let's continue to educate. Because if there is an integrated approach to this, there is a higher chance that this person will remain stable. And again, we're not talking about perfection. I mean, I'm sure some of you have had experiences where people is like, well, I'll reduce my use, but I won't stop using, or I am not really an addict, but you know, you might be like, oh, I don't know, I see all the signs that you might be. It matters in terms of diagnosis and prognosis, but access to treatment is important, right? If they are connected to treatment, if they have someone to keep eyes on them, if they have someone that will make it more difficult because of whatever reason to use, right? Because of accountability, I'm going to have a urine drug screen. Because of consequences, right? I have a stable and living environment, I have a job, I have all these things that I don't want to lose. You know, and as long as I'm here, I'm not going to use. Fantastic, we'll take that for now. No wrong door. Whatever works to keep them safe, to keep them connected to treatment, to keep them accessing services. To, again, I always tell people, protect that brain. Whatever protects that brain works at the moment. Okay, language matters. This is another way to reduce a stigma and to be able to have a more harm reductive approach to our loved ones with an addictive disorder. So for example, right, withdrawal is a medical condition. It can be fatal if untreated. Instead of telling your loved one, you know, you need detox, you know, you're in withdrawal, you need medication for that. You're in withdrawal, I'm afraid that you're going to get sick or have negative consequences. Maybe you need some, you know, a doctor, or you need medical assistance for that. You're saying the same thing, but you're saying it in less stigmatized way. You need detoxes. I'm going to send you to a place, usually not a very nice place, you know, to have a couple of miserable days so you can, you know, recover or get in recovery. So medical assisted withdrawal, much better than detox. Again, you're an addict or an alcoholic. We might think that, we might even be right? But the truth is, the person needs to identify themselves as an addict or an alcoholic for this to be part of their identity, of part of they want to work on. It might be easier and might open this person to talk to you more about their substance use disorder if you say, you know, it sounds that all these problems and all these things that are happening in your life make you meet criteria for substance use disorder. Usually people can get treatment when they meet criteria for this. Objective, not stigmatized. You're an addict is like almost finger pointing. You know, you meet criteria for this is like, I'm just stating the facts. Again, the person will eventually, as they learn about themselves and as they learn about their disease, choose to identify as an addict, as an alcoholic, as an overeater, as a whatever addiction they have, as having a gambling problem. Is that something that we need to impose of them? No. So again, my family member has an alcohol use disorder, much better than my family member is an alcoholic. So how do we encourage change? This is actually really interesting because actually yesterday I was doing another webinar for a different group, and one of the people in the webinar asked me a question that very few people ask during these webinars, and she's like, well, what do you think about harm reduction? And I was like, you are so good, because very few people knows thinks that harm reduction is a good idea. And maybe we have also, you know, not the right information about what harm reduction is and how it works. But it's evidence-based, and is associated to motivational interview. And the reason why I'm going to talk a little bit about motivational interviewing is because the techniques of motivational interviewing help you have a better conversation with your family member about substances. It helps you use a harm reduction approach to substance use instead of a more, like, again, stigmatized way of conceiving and talking about substances. So the definition of motivational interviewing is a person-centered counseling style for addressing the common problem of ambivalence about change. So motivational interviewing is actually a counseling technique, but it has a couple of components that are very easy to use by anyone, really, right? It has a relational component and it has a technical component. So the relational component is basically showing empathy. Empathy meaning I understand from a personal level what's going on. Not I just like, I feel sorry for you, or, you know, that must be really hard. But I can connect with your experience in a way. Maybe I can, I don't have the experience, you know, I don't know, using marijuana, or, you know, having to self-medicate with opiates, or whatever the experience is. But I do understand how sometimes you want to do things to get rid of your pain, because we all have that experience. As adults, we all understand that sometimes we want to do things that might not be the healthiest ones to get rid of our pain, right? So if we can use that place of empathy, that place of, I do understand the concept of you wanting to not be there, that you wanting to make that experience that you're having stop, that you would like your life to be different, that I understand that. I don't understand your experience when you're high on something, because I've never been high on that, unless maybe you have, right? But I do understand why you would like to go to that place, because I sometimes don't want to be where I'm at. I understand that. So that's empathy. And then the evocation and encouragement of change talk, which basically means, okay, well, what do we do for you not to be there? I you know, like, I legitimately don't want to see you suffering. What can we do for you not to suffer? What can we do to make it better? So how do we do this? We elaborate. So we ask additional questions, right? Again, you avoid why, because why, it's very judgy in general. Just remember, when you ask, like, why are you doing that? Sounds very judgy, right? But you can be like, who can help you? What can we do to make this better? When would be the best time for me to come and help you? You know, like, again, ask additional questions. And the important part is to make sure that the answer or the solution to this quote unquote problem comes from the person, right? When you, instead of saying, well, why, I'm going to take you to this place to be treated, asking, what do you think you need in terms of treatment? Do you think you need treatment? Or like, what do you think about this place? Do you think they can help you? Again, when the decision is made by the person that has the problem, you have a higher likelihood of actually him or her being compliant, him or her sticking to what they have chosen themselves. So it is important to ask questions. Who can help you? What can help you? When or how do we make this happen? And again, avoid why, because why usually means judgment. Affirmations, accentuate the positive. Acknowledge strengths, acknowledge effort. Not praise, that's different, right? You don't have to say, oh, great job for coming and talking to me. I mean, it sounds fake, right? But saying, I do appreciate you telling me about this, or I do appreciate you talking to me about this. I know it's difficult. I know you want to talk to me about this. I thank you for taking the time to answering my questions. Again, affirmations, which is not the same as praise, acknowledging what's positive, right? I do, or if they tell you, well, I've been trying to stop on my own. Okay, I value that. I appreciate that you are trying. I didn't even know you were trying. I didn't even know you were trying to stop. That's important. That gives me, that tells me that you're really trying to make things better. Again, not saying necessarily good job for trying on your own. Maybe it's not even good to try on your own, right? But at least they're trying, and acknowledging that is important. And then reflections, which means basically being able to repeat what the person is saying. Why are reflections important? Because people feel heard. And it makes you hear better too. Like if you think about it, you have to pay attention to repeat what people is saying, right? You need to be slow. You need to slow yourself down to hear the person telling you things. So reflecting it's a very good way to convey, I hear you, doggy, stop barking. So part of I hear you, it's I am actually stopping and listening, and I'm able to repeat what the person is saying. And you can also reflect feelings, right? Again, that takes paying attention to the person. But I can see you're upset. That's reflecting a feeling. I can see this is difficult for you. You're telling me that you've tried all these, and you can enumerate what the things are, and nothing has worked, right? I can see that you're unhappy. You're telling me all this. So reflect what they're saying, which is paying attention and being able to repeat, but also reflect the feeling. That's even more powerful, right? If the person can feel understood because they understand that you are actually paying attention to how they're feeling. You can even clarify, right? Like, you're crying. Is that because you're upset? Is that because you're sad or mad, right? Clarify, but notice that they're feeling something, right? You stop talking, you clammed up. Is this very difficult? Am I upsetting you? That is important because it shows that you're paying attention to what your loved one is talking about, doing or not doing. So again, slow down, pay attention, reflect. It really makes the person feel heard. And then summarize, right? Again, make sure, especially after your conversation, summarize where the conversation got, right? Especially if it was a good conversation, you got somewhere, make sure you summarize. I hear that you are upset about, losing your job, or that your girlfriend is upset because you're using. We agree that maybe we should go see this doctor, right? I'm gonna call to make an appointment. Something like that, something simple, right? I hear that you are telling me that you don't want me to nag you about this. I am not gonna nag you anymore because you told me that you are going to do this. Whatever it is, but a conclusion, a summary of where the conversation got. Treatment considerations. Again, what do we treat first? As I said, no wrong door. That's what we need to know. It's a chicken or the egg thing. Whatever comes first, you treat. And as you treat that, you treat the other illness as well. Treatment modalities for substance use, cognitive behavioral therapy or CBT. CBT is focused on changing thought patterns and identifying elements of your experience. So if you think about it, if you have a mood disorder, which is, again, very common, it's a very common comorbidity with substance use or a substance use disorder, you sometimes don't stop. And this, what we just talked about will help with that as well. It's actually motivational interviewing is a cognitive behavioral therapy technique. But what cognitive behavioral therapy does is basically makes you stop and look at your experience and pay attention to it. What am I feeling? How am I behaving because of this feeling? How does my body feel because of this feeling? What am I thinking when I'm feeling this? So as you identify the elements of your experience, you're able to address those that need to change, right? I'm feeling miserable. Do I really want to feel miserable? Likely no one wants, right? How do I change things? How do I change those elements of my experience so I don't feel miserable? How can I intervene on that experience to make it different? Dialectical behavioral therapy is a spin-off of CBT. It works very well with people that has problems with emotional regulation because it adds an additional element. If you think about CBT, you actually need to be able to pay attention to your experience to work on a CBT model. If you're like really dysregulated, think about yourself when you're like really anxious and can only focus on what makes you anxious, or like you're like really sad and you're like, tearing up and really just can focus on what makes you sad, or even if you're really angry and you like just want to fix what makes you angry, you really cannot think about your experience, and you're going to be like, oh, what am I thinking that makes me angry? How is my body feeling? You'll be like, stop it, I just want to break that. Or so dialectical behavioral therapy adds an element of emotional regulation so that you can do the work. So the first step on dialectical behavioral therapy is actually mindfulness. It's actually accepting the here and now of your experience and working with that very sort of heightened experience and regulate the emotion to a level that you can actually do the cognitive work. So think about, anxiety, right? Going from 0 to a 10. If you are at about, and this I teach my clients all the time, if you're at about an 8 to a 10, you don't want to hear anything that I want to tell you about therapy. No one wants to hear anything when they're at 8 or 10. They just want someone to fix it, right? So dialectical behavioral therapy helps you to keep it under 8, right? So when you heighten your anxiety, maybe you'll now just get to a 6. 6 is bad, but it's manageable and you can still do the work. So that's what DBT introduces into the picture. And then ACT, acceptance and commitment therapy. Actually, I like this a lot for addiction, especially for addiction and pain and addiction and dual disorders, because sometimes there's things that cannot be changed. Think about pain, for example. If you have a pain condition and you're addicted to opiates, right? Common thing. Pain cannot be changed. If your back hurts, your back hurts. If your knees or your joints hurt because you have arthritis, they hurt, right? So telling someone that part of your experience is going to change is unrealistic, right? Or like if you have bipolar illness or a psychotic illness or even anxiety, right? Telling someone that you're not going to be anxious or that you're not going to have the experiences associated with your depression or your psychosis is unrealistic. So sometimes you have to learn to let that experience be what it is. And that's what ACT introduces. Basically, the fact that you can, there's a meditation for ACT called the falling leaves meditation. And it basically tells you to put whatever it is that is bothering you on a leaf and watch the leaf, sort of slowly fall and float on a river. That's a good analogy for what ACT does. It's basically look at your experience, put yourself outside of your experience, and just look at it and accept that it's there, because you're not going to be able to not have it, basically. So those are very common modalities that work very well with dual disorders. I put it here, consideration of current recovery status, because you can make someone work, like I said, on something like CBT if they're still contemplating change. So maybe you can only do some of the motivational interviewing that we explained before, or maybe we can start with like more dialectical behavioral therapy approaches, because they're still not yet ready for change, right? Although, like, you have someone that has relapsed multiple times, for example, and they're frustrated because they keep relapsing. Maybe ACT, acceptance and commitment therapy, will be a better approach for them, just because, part of their experience is that they're going to accept the relapse. They're going to have to look at that relapse, learn to put themselves outside of it, and look at it as a floating leaf. Relapse is going to happen to me. How do I get ready for that? I need to accept that as part of my experience. So that's important, because again, addiction is a chronic illness. You have the beginnings of that when people are in the process of accepting that addiction, and you have the sort of more chronicity of that when you have to accept that relapse is possible at any stage of the game. The 4-quadrant model is important also because it tells you sort of how do we make the decisions about level of care. I mean, this is more like telling you how do we decide level of care for your family member, right? So this intersects mental illness and substance use disorder. So if your substance use disorder and your mental illness are severe, obviously you're talking about higher levels of care, right? If your substance use disorder is low, but your mental illness is high, then you're talking about a primary mental health setting for treatment. If the substance use disorder is high and the mental illness is stable, then you're talking about a primary substance use setting for treatment. Think about someone, for example, that might have anxiety, but they're like relatively stable with it, but they need to detox from something. Substance use disorder becomes primary. That's what needs to be treated first. If, on the other hand, someone is having suicidal ideation and they might have also a substance use disorder, we're going to treat the suicidal ideation and we're going to treat the substance use disorder secondary. So it really depends on what is the priority at the time. And this might change throughout the lifetime as well, which is okay. Again, no wrong door. Whatever needs to be treated, we treat, and we treat the other disorder as we're treating the primary diagnosis. So in general, working with people with substance use disorder, it's complicated, especially with this co-occurrent, right? Our clients are usually not really trustful of the treaters. They are not really happy to hear that this is a lifelong condition. And especially when young, they want to try for it not to be, right? They want to try again. They want to make sure, they want to get feedback from the world telling them that they don't have a chronic illness. So it's really, really hard. It sometimes takes a while and takes many trials for the person to commit to treatment, to trust treatment providers, to accept that this is a lifelong condition. And the best thing that I can tell you is make sure that there is someone there. Like, that's what we try to do at CRS. We will be there for them. That doesn't matter if they relapse. It doesn't matter if they need a hospitalization again for their mental illness. It doesn't matter what it is that is making them not make progress. We will be there because, again, remember, no wrong door. Whatever is the problem, we'll address at that moment. As long as there is comprehensive treatment that can address all the problems, we will deal. A successful therapeutic alliance is built on empathy. We talked about that, and support. So empathy, we practice all the time at the program again, trying to connect in any way we can with the experience of our clients, and support for all our clients' needs. And that's important to know. It's important to know that people with co-occurring disorders, especially young people with co-occurring disorders, they do want to make sure that their lives are supported. So they don't only want to hear about their meds, they don't only want to hear about compliance with treatment, they want to hear about a job, they want to hear about relationships, they want to hear about the future, they want to hear about education, they want to hear about those things being supported as well. And of course, part of this is making sure that they're medically stable and that we're continuing to support their medical treatment just to avoid any medical complications for them. Relapse prevention skills is a critical component of comprehensive care. This is especially important because, again, relapse, it's likely to happen. So the more power that we can give them over the relapse experience, either will reduce the number of relapses or will reduce the amount of time between relapse and engagement in treatment again. Again, if we can reduce the number of relapses and reduce the number of time in between them relapsing and continuing treatment, we're saving that rate. So that's our goal, right? The least relapses we have for both mental illness and substance use, and the least amount of time in being ill in between relapse and treatment, we're doing our job. And you are doing what you can. For clients with depression, cognitive behavioral techniques and behavioral activation and medication evaluation are core services. I know some of you do have family members with depression, and again, CBT, acknowledging your experience, learning about what are the elements of that experience. It's important. Behavioral activation, sometimes we have to do things before we actually enjoy things. If you're depressed, you don't want to do anything. So part of the process of behavioral activation is putting things in front of you for you to do them, right? Medications are super important for mood disorders as well. And the other thing that I would add here, although I think it's here later with PTSD, is the bottom-up approach. So there are two kinds of approaches for treatment. There's like top-down and bottom-up. Nothing wrong with either, right? But sometimes when top-down, thinks about your frontal lobe working. So talk therapy is a top-down approach, right? You talk about your problems, you try to problem solve, you try to figure out how to address things. That's a top-down approach. Sometimes that doesn't work, especially if you're very depressed or you have trauma, right? So bottom-up approaches sometimes are the best approaches for people that are very debilitated. Think about very experiential therapies. Think about doing therapy, right? And this is my thing. If you guys know me, I am the dog lady. So pet therapy is a bottom-up approach. The relationship with the dog, it's very sensory, right? I'm petting the dog, I'm touching the dog, I'm taking care of the dog. Very sensory experience that might provide the behavioral activation that someone with depression has. Same thing with trauma, right? I might not be able to talk to you because I'm not right now having a trauma response, but I can pet the dog and I can talk about the dog. There's similar experiences with like equine therapy. There's some similar experiences with art therapy. We now at CRS have a music therapist that is doing that same kind of intervention, right? That's a bottom-up approach. You might not be able to have a group in where you talk to others about what's going on with you, but you can talk about music and how you relate to music. If that's the entrance to being better aware of your experience, we're doing work with you. So that's important to know. Clients with anxiety may need treatment tailored to anxiety diagnosis. A very common intervention for anxiety, I think we've done that before, is exposure response prevention, which is a very cognitive approach. again, that in conjunction with a bottom-up approach, like having a very sensory sort of grounding technique as the beginning of exposure response prevention might make a big difference for like chronic anxiety, generalized anxiety disorder, PTSD, or even OCD. And then for trauma, as I said, bottom-up approaches are the best and most effective treatment, and obviously safety seeking, which is part of the ACT model as well, and trust building will be cornerstones of treating PTSD. Resources, I will be sending this to you. There's plenty of resources actually for substance use. It's, you know, unfortunately to a certain extent, there's well-developed resources for substance use. There's in the incipient stages, most of these phases, if you look up SAMHSA or NIDA, about adding co-current resources and resources for parents. I have a couple of things that I also downloaded that I can send to you when I send materials to you. But that will be it. I'm gonna stop sharing now and hopefully I'll get some questions from you. Or if you can even tell me if you want me to expand on anything, I'll be happy to do that for you. We do have about 10 minutes for questions or to expand on anything you want. Hi, Liz.
Hi, thank you. Didn't you say that there is CBT but not DBT? And how often does it happen and how successful is it? And why don't I hear about it? And is it, you know, I just...
So there is both. I personally am not a DBT therapist. I do practice CBT when I do groups and everything like that. But I mean, if we're talking about in our program, we do have a couple of DBT certified therapists. Holly, our program director, is one of them. She is DBT certified, so she does a lot of the DBT groups. You know, there is a lot of, like, I think Alice does a lot of all of the mindfulness and sort of like bottom-up approaches that are included in DBT. So there is, we are not a DBT program and we're not a CBT program, but we have both approaches as available to clients in the program. So what we use of DBT are most of the first step of DBT, which is the emotional regulation techniques so that you can engage in treatment. That will be mindfulness, that will be all the meditation techniques that they learn, that will be all the art therapy that they do, that will be all the, again, bottom-up approaches that we have so that people can regulate. Remember, when we talk DBT, is let's make sure we bring you to a 6 or a 5 so you can actually do the work. So that's what they're learning with Holly most. Yes.
You said it's available, but is it required? Is it really part of the program for my son?
So, well, your son is on the step 3 of the program, and he works, which is it's part of the program for him, and it's very, you know, rewarding for him. He does have access to groups. I think he's attending mostly the art groups, which are not bad. And I've seen his
the what groups? The what groups?
Art groups.
Art.
Yeah. I'm telling you, I can tell you how much I've learned from him from looking at his drawings and stuff like that. He is really using those groups. And again, that is a bottom-up approach, right? So even though you might think it's art and he's making drawings, that is allowing him to connect with who he is. He is, you know, making progress that way. And maybe later, once he gets comfortable with the art approach, he can move on into more top-down approach, more talk therapy. But right now he's using the bottom-up and he's using it well. And you know, and again, you remember motivational interview and harm reduction. We meet them where they're at. You know, if he is doing work with art, and again, I can assure you he is doing beautiful work with art, you know, then let's do that with him.
He used to do, I wouldn't call them political cartoons, but cartoons. I mean, kind of sarcastic. He wrote for he drew for his newspaper. That kind of art, or just like adult coloring?
Nope.
Not adult, okay.
No, the cartoons, actually. He's doing a lot of cartoons. It's pretty good. I like him. Very smart, and you're right. There's a lot of behind on the cartoon. So yeah, I mean, whatever works, right? Some of our clients are doing the dogs. Some of our clients are doing music therapy. That's very popular these days. So again, a lot of the bottom-up approaches are a good beginning to connect yourself with your experience. And I mean, some of our clients cannot even tell us sometimes when they first come to us what they're feeling, right? They cannot put a name to the feeling, but they might be able to put a name to the feeling when they listen to a song and talk about the song with our music therapist. So sometimes it's hard to connect when you're like asking the frontal lobe to talk about things. You have to start with like the primitive brain to tell you in different ways what's going on. So cartoons work. They're working. Go ahead.
Anybody else?
Yeah, I don't know. Was there any other questions?
Yes. I have a question. Can you hear me?
Yep, I can hear you.
Okay. So my son is in the program, and he grew up, working with dogs and horses. So things you mentioned, dog therapy and equine therapy. He's relocated in New Haven, and we've struggled to find him these services. So how do I go about getting, the staff working with him to kind of help him identify these services? And also some providers within COC family instead of going outside.
So like I can tell you, for the pet therapy, if he's still going to CIBH, talk to his therapist at CIBH, and I can arrange for the pups to come. I mean, they go everywhere in Continuum, so they can come. That would be an immediate thing. I think we do have connections with a couple of equine therapy practices, and again, you can email me or you can ask the therapist at CIBH directly, and they can connect them with them. I know that my supervisor John had made contact with some of the programs, and I believe, I don't know if like Matt will be his therapist at CIBH or Susan, but they had explored a couple of equine therapy options as well. So we could connect you with that. The other thing, I don't know much about your son, but we could even like include them in some of the art groups or music therapy, if that's something that will work. So ask, we have plenty of resources.
Okay, sure. I'll get your, I don't have your email. So if I could reach out to you and we can take it from there, because music therapy is another option he's used to and exploring.
I'm putting it on the chat right now.
Wonderful. Thank you so much.
All right, here we go. Yeah, anyone, if you have any questions about any kind of, again, these bottom-up approaches that we talked about, either we provide them at Continuum and so our programs already, or
I don't see your email.
Sorry, I put it for only someone. I will actually put it for everyone. Hold on, just a second.
Okay, thank you.
Hold on. At continuum.org, and I will put now everyone. Here we go. Okay, you should see it now.
Yes, I see it. Thank you so much.
You're welcome. Yeah, no, anytime. We already have a lot of these services in Continuum or already connected, so happy to help.
Yeah, I would much rather go with something that Continuum is engaged with and has been tried. So definitely this is most welcome.
All right, no problem. All right, we have a couple of minutes. So if anyone has any other questions or would want any information, as usual, I'll be sending all this information via email If you register, I will get the list and I'll send it to everyone. If you have any questions, my email is in there as well. You can send the questions to my email. And I hope to see you the next time. Liz, you have 2 minutes.
Okay, I still didn't, you referred to bottom up, but then you said, then later it would be top down. What's an example? Top down.
Top down is traditional talk therapy. You know, it's the more, like, it's, think about, you know, psychoanalysis, for example. That's a top-down approach because you talk about things, right? Think about even cognitive behavioral therapy is a top-down approach. The bottom-up approaches are more the experiential approach. So art therapy, music therapy, pet therapy, you know, even like some of the mindfulness exercises that are very much like, you know, grounding exercises, those are top-down. I'm sorry, those are bottom-up. Top-down are when you have to think. Think about anything that you have to think about, right? When you have to use your actually big person brain, not your primitive brain, that's a top-down approach. So mostly talk therapy, psychoanalysis, again, cognitive behavioral therapy, solution-oriented therapy, narrative therapy. There's a bunch of approaches that are top-down. They usually require the person to be insightful and be able to talk about their problems, which a lot of our clients are not ready when they come to us that way, right? They do get ready as they progress in treatment, but usually bottom-up works best first.
Thank you.
All right, well, thanks everyone. And as I said, I'll make sure to send this information to you guys. And if you have any questions, you have my email in there now. All right, bye-bye.
That's it.
Thank you.
Bye-bye.
Bye.
Thank you.